So I worked about the cerebellum, and I must say, I think I'm going to present a lot of problems, a lot of misdiagnosis, a lot of confusion. So instead of calling it, just going through all the pathologies, I'm going to raise more of the problems and not necessarily give all the answers. So this is not my original name of the fetal cerebellum, small brain, big confusion. Many of the important people dealing with this, like Bolthauser, and that have given many of their lectures that deal with that. So, as an outline, we're going to talk a little bit of the old classifications. I'm going to try and go into the new definitions, etiology and genetics, some anatomy, very few examples, and then we'll try and talk about the good, the bad, and the ugly, the uncertain cases that make our lives so complicated. So these are really short-term cerebellar atrophies, usually a postnatal process. Hypoplasia is a small but proportionately normal cerebellum, dysplastic cerebellum of the disorganization, and of course we have a confusion with the agenesis or the hypogenesis. And I'm going to go real fast. No more Dandy Walker variant. I still see it in the literature, and it's very surprising. It's a very complicated that. I've seen it in articles coming from 1 year and 2 years ago, and it's very surprising that people are still using Dandy Walker variant. It's confusing. It does not mean anything, and we really have to stick to the definitions and try to do it. So the cerebellum is one of the earliest cerebellar structures to develop throughout the pregnancy. It matures for a very long time. So I think if there's one thing you really have to learn here is that if you're suspicious that there's a problem and there's an abnormality, and it's important to follow it through to late pregnancy. Don't make a diagnosis very early. Many of the false alarms that we had or the misdiagnosis were cases that were diagnosed very early in pregnancy, and when you follow that through, they normalize. This long period causes the cerebellum to be particularly vulnerable to a broad spectrum of developmental events, and the biggest problem is that there is lack of consensus regarding the terminology used. This is the old classification. This is from Patel and Barkovich. We used to classify. It was very easy for the radiologist, and for that we looked at the cerebellum, we looked at the vermis, we looked at the various sites. Well, things are getting more confusing and not very easy. So this is the old classification. I'm going to take this off because it takes my thing. So we looked at the posterior fossa. We divided into cystic lesions. We looked to see if the TCD, the transverse cerebellar diameter. I'm going to talk a lot about ultrasound, and I thank many people here in the audience, and some that I will give credit for all the ultrasound, because I do not perform myself the prenatal ultrasound. And then there's the focal anatomical cerebellar lesions. And this is all Patel and Barkovich and Parisi and Dobbins. This was in the beginning of the 2002, 2003, and of course Laurent Guibault has written a lot about it. Well, this is all passé, no more old classification. Since the advantages in genetics and imaging, we understand a little bit better the embryological development, and I'm going to pause a little bit on this I think it really helps us. If you understand the embryology, then you're going to understand the pathology that you're going to look into. And so there's the new classification that correlates with these embryological morphology, and it's very complicated. For example, and Elodie, you've shown these amazing cases of cerebellar malformations with known genetic causes. All of these are known. They are probably very famous ones like Dandy Walker malformation or Relin, but then we have cast and part of the tubulinopathies. And this known knowledge in genetics has helped us to come with the embryology and made it very, very complicated. So the two most important people right now in the field are Dan Doherty and Barkovich, and together with Dobbins, they really set it all up together. And the practical points are that we should try to distinguish the different cerebellar malformation conditions important for the prognostic and recurrence, and it's very important to work together as a multidisciplinary team approach. We really need the radiologist, the neurologist, the genetics, and it's very important to understand. I'm barely following the names of the different mutations. Each mutation has a protein, and then they're calling it by different names. It's very complicated. Okay, and it's very important to understand that there is a lot of overlapping neuroimaging and clinical phenotypes. So this is the review article, the important review article of Barkovich with Dobbins. It came out at 2009. I think I read this article, I don't know, I think close to 20 times. I still get it. It's very, very complicated, and it's divided. We're not calling it anymore the cerebellum. It's all called the mid-hindbrain malformations, the midbrain and the hindbrain malformations. And it's really important to understand that the malformations within the central nervous system and the central blood remains limited. It's based upon embryology and genetics. It is not very intuitive as a radiologist, as an sonographist. It's very, very complicated, and it still is. The whole anterior, posterior patterning disturbances are problematic. There is the abnormal cerebellum, and we can still relate to the different malformations that we know, but we really have to understand the different terms and the understanding. So there is the ISO organizer that sits here between the midbrain and the pons, and it sends a couple of proteins all over the place. Many of them are known as for different genetics, and this is all described in the Frontal Neuroanatomy in 2012, and it causes all kinds of abnormalities, mainly in the brainstem. This is an area that we haven't looked into very carefully, I think, in the past years, and the pathologies were there. And to understand that, we have to get a little bit back into the basic embryology and the neurological tube. They are the most important. There is the superior membranous, and then there is the inferior membranous. And this is how the vermis and the cerebellum starts to develop. There is the fold of the plica choroidal that later develops the choroid plexus. The upper portion is the important, it will grow out and turn into the cerebellum and vermis. The lower portion is actually an outpouching of the Blake's pouch. And the Blake pouch, which is an old term that we haven't used for many, many years, is really the most important point in posterior fossa anomalies into them. And this is adapted from Robinson and Goldstein in 2006. This is the tube as I look at it, the superior part and the inferior part. And in the back wall, it's divided by the choroid plexus. So the vermis will develop from the upper part, and the Cisterna Magna will develop in the lower part. And this is all, this will become into holes and turn into a cystic lesion. So with time, you see the vermis and the cerebellum developing, and this is the lower part of the vermis. This is the choroid plexus, and the relation of the choroid plexus to the various anomalies is probably the most crucial part. Even though we don't always recognize it, that's the most important part. And the Cisterna Magna is a separate fluid collection that will develop on the lateral aspect. Okay, so the Blake's pouch is actually an outpouching in the medial aspect of what will later develop into the parts of the Cisterna Magna. And at the end, the medial portion of the Blake's pouch will be the foramen of Magendie in the center. The lateral parts would be Luschka. And this will incorporate, this fluid cyst will incorporate with the Cisterna Magna. So for those of you who perform ultrasound, you can often see it, and this is again coming from the literature, that the hypoechoic area is the Blake's pouch. It's actually the remnant of the Blake's pouch, and the lateral aspects, which are a little bit more echogenic on the axial images, are the parts of the Cisterna Magna that then will come together. And then here are the choroid plexus and the various parts. So these are the axial images of the Cisterna Magna. It's very important to evaluate the normal vermis. We're on the 9 aspects of it. I never get their names right, I'm sorry. I always have to open a book and get again and look into them. But it's important to recognize the primary fissure, the secondary fissure, which divided up into 3 various portions. The fastigium is important. And these are pathologies coming from Adamsbaum 2005. And you can see the development of the folia throughout the ages. These are axial images lent to me by Israel Shapiro, who's here, and for the demonstrating very nicely. Unfortunately, in life, they don't usually come with a marked and showing us which part of the ultrasound it is at 26 weeks of age. And I think this slide is like for a long time ago, and I'm really very fortunate to be working with a lot of amazing sonographers in Israel. And you can see the very nice vermis dividing up the normal and cerebellum on both sides. Now there's a lot of confusions. Many articles have been written about it. This is Bolthauser and Laurent Guibault, and of course the group of Tali and Gustavo Mallinger. And why is it so complicated? When we look at malformations of the posterior fossa on the prenatal diagnosis, then we know that we make mistakes in 57% of cases. This is the study by Carol when she looked into that if we think that there's an abnormality that we find prenatally on ultrasound and on MRI, 57% of the cases we are wrong. We do a follow-up MRI and everything looks okay. Now why are we so wrong in this subject? We're very good in looking at it. So there are various, we're trying to explain it. There is a confusion of terminology. Some of the anomalies are either appreciated or they develop later. We get confused between hypoplasia and atrophy. And in Populus in 2006, when she looked into the follow-up, she saw that in 32% of cases that they were diagnosed with vermial hypoplasia. Today we do not call it inferior either, and this is another thing we'll talk about. Today it's actually not the inferior part because we know that the vermis develops and surrounds it. So vermial hypoplasia in utero, in 32% of the fetuses, the postnatal was all normal. So we're in a big problem right here, and these are articles that were in the end. Now, another reason, a way to look at it, even if we perform fetal MRI, and it may be affected by a significant risk of, we can be wrong both ways. It can be a false positive, and it can be a false negative. And the pathology confirmation of the posterior fossa anomalies have been reported to have a low level of corticodence with prenatal imaging. So we don't even know which ones and how bad they're going to be. So there's a confusion between the different entities. The Dandy-Walker variant, which shouldn't be used, the malformation. Some call it hypoplasia. And it's also important to look and wait till the premature diagnosis of the vermial finishes to perform. Even though they make it seem very easy, in clinical practice, the distinction is much less obvious, and this has caused a lot of confusion. So the one take-home message here is look at the mid-sagittal plane. This is the most important plane that you can look into. You have to do the measurements of the length and the width of the pons, the ratio between the superior and inferior part. Always look at where the Cisterna Magna ends and where the insertions is and how big the whole posterior fossa is. Is it a big posterior fossa and the size and the shape of them? And you can see with ultrasound how they grow with time and their variability. So the vermis is important, the tectal plate, the midbrain, the pons, and the medulla. And if we look at the various parts, this is a work by Vienna. You can see that they can even call the different, this is Daniela Pryor and Kasparian, that you can really see the different segmentations of that. Now, one more point. The Doherty has identified it and defined it very well. And this has been also assessed by ultrasound. Look at the brainstem. Look at the relationship between the midbrain, the pons, and the medulla. They should be between the obex and the floor of the third ventricle. This would be divided by 1, and the pons is usually 1.5 to 2 times bigger, and then the medulla is 1. The fastigium, this is the angle here, should fall immediately in the middle of the pons. You should identify the various, at least the primary and secondary fissures, and see that they come in the middle of the brainstem. And all these important points and identifying. Now look at this. These are various, this is lent to me by Gustavo Mallinger, and these are different cases, each case at different ages. All of these patients, and maybe yours, have been referred because of an abnormal vermis. People thought that this was either hypoplastic vermis or abnormal or Dandy Walker variant or malformation. All of these patients were normal on third trimester. They have normal development. So it's really, really important that when we see an enlarged retrocerebellar fluid space with a normal or abnormal cerebellum, we have to differentiate between the Dandy Walker, the Blake's Pouch Cyst, Megacisterna, and Vermis agenesis. And the secret lies in the vermis. Is it dysgenetic or normal? When we look at the cyst malformations of the posterior fossa between 2000 and 2008, we're seeing that most of the cases were Blake's Pouch Cyst and Megacisterna Magna, and very few were Vermis or hypoplasia. When we look at the Robinson at the 2014, he tries to develop them to categorize the cystic lesions, and here also there's a lot of overlap between the vermial hypoplasia. I think the differentiation between a Megacisterna Magna and arachnoid cyst, even though there's a lot of literature in the fetal world postnatally, whoever is a radiologist postnatally, it's very difficult to differentiate between them. We try to look at the fact that there is compression and there is a mass effect due to the arachnoid cyst, and actually sometimes you see remnants of the Blake's pouch, but differentiating between them is not so easy. The important is to identify the normal appearing vermis. And again, we're trying to attempt to differentiate between the arachnoid cyst and the Megacisterna Magna. So I want to show you this case, and that this is a persistent Blake's pouch cyst. This was referred at about 28 weeks of gestation. You can see the vermis rotated counterclockwise. Do you think it's normal? Abnormal? Right? We're standing like this, all right? Okay? And you have to really follow it up. It's easy said, we try to look at this, the fastigium, is it a little bit open? Most of the cases with persistent Blake's pouch, the fastigium, even though they tell us that it should be normal, it's a little bit open because you can see the cyst coming in there. Is the primary fissure there? Yes. Does it look a little small because it's compressed or not? These are very difficult things in life. According to Robinson, we should look for the choroid plexus. I think it's almost impossible to see the choroid plexus, definitely even postnatally, but better alone prenatally. So according to the way that the development, the anatomical development, the foramen of Flushka in human beings are very small. So it causes the enlargement and elevation, rotation of the vermis away from the brainstem, and there's a gap. There's also a lot of literature coming that measures the angle between them and the angles of that, and I didn't get into that. But we make a lot of false positive diagnosis of Vermian hypoplasia. What do you think about this case? Right. Let's not look at axials. Well, I think I got one point here correctly, that we should always use the sagittal images. This is at 25 weeks. You could see the Blake's in the middle, okay? And this is a nice presentation of the Blake's pouch cyst in the middle, coming on both sides of the cerebellum. And when we look at it on follow-up, you could see again another explanation of the Blake's pouch cyst and the way it develops. And you can see the tentorium is normal, the vermis appears normal, the fastigium looks okay. And when you follow up on these cases, You can see the persistence, and actually sometimes, I think on ultrasound you see them much better, especially on these weeks. You can see the nice resolution of the primary fissure and the fastigium. And with time, at 32 weeks of age, we did not perform another MRI. We just did a follow-up ultrasound, and normal cerebellum, the vermis, and this child is normal. So this is a very important, and Blake's pouch, normal anatomy, fastigium, mild to moderate anti-clockwise rotation, and normal size of the Cisterna Magna. The Dandy Walker malformation, I'm sorry, but I have no watch on me, so
It's fine.
how many?
Don't worry. It's fine.
How long now?
It's very interesting.
Okay, keep going. Okay, well, Dandy Walker malformation. There is a complete or partial agenesis of the vermis, anti-clockwise rotation, and large posterior fossa. This is the most important part. We have to have the elevation of the insertion of the tentorium, again, on the sagittal image. And there's a large fluid collection in the cisterna communicating with the fourth ventricle. And this is, they thought it was a reason for hydrocephalus. This is only frequently associated. So the Dandy Walker continuum, as you can see it here, is again, there are two theories about it. Some think it's related to the enlargement of the Blake's pouch cyst. Others think it's an abnormality of the primary abnormality of the vermis. It becomes extremely enlarged. You can see the tentorium, and this is something I learned from Laurent Gubaud also. How do you know that the posterior fossa is enlarged? I think this is something that is easier on MRI than on ultrasound. You see where the attachments of the muscles are. And the attachments of the muscles should be are about here. So definitely the tentorium is much bigger than it should be. I think on ultrasound it's very difficult to see exactly the attachments. Maybe the different angles will help us in differentiating the differences in the Dandy Walker malformations. And on the axial images, again, you often see this kind of thickening on the superior part of the cyst, and you could see the vermis, which is totally abnormal. There's a large difference in the size of the vermis. It could be very hypoplastic or very abnormal. The prognosis depends on an associated CNS abnormalities. The mortality is quite high. There's a lot of genetic abnormalities. And the interesting thing, and I think we haven't heard the end of Dandy Walker malformation, there's a lot of work coming from France. I think we really have to understand why in 50% of the cases there is a normal intelligence. And I think we're looking on a spectrum. Many people are not using the term of Dandy Walker malformation, but rather Dandy Walker spectrum, because we are not yet able to differentiate. We've had a couple of cases that have looked into that, and we did not, they came with a second Dandy Walker look-alike. I was sure it's a Dandy Walker malformation. The pregnancy continued, and the child is normal. So it's really, I think we haven't heard the end of the Dandy Walker malformation. So I'm going to look into a little of the controversies. And when we look into that, it's really difficult to distinguish between the Vermian hypoplasia and Blake's pouch cyst. In the literature, these two groups have always put together, and they were not well differentiated, so that we cannot tell which one has a good prognosis. And again, we're back to the vermis appearance. So you really have to ensure the vermis is normal, and if all of it is there, just continue and following it. The work from Guibault says it's often impossible to determine prenatally if vermial hypoplasia is isolated. So we have to check all these cases for genetic abnormalities, and they have something like 40 or 50% of them. Another work coming from Godolphi Pilot, 50% of Dandy Walker and inferior hypoplasia have abnormal outcome, even if they appear to be isolated prenatally and postnatally. So prenatal MRI cannot differentiate, and this is Palladini in 2012, between vermial hypoplasia and Blake's pouch cyst. So confused? Well, I'm even more. And when I look back, these are very old images on 24 weeks of age. I called it a vermian hypoplasia. I'm not sure I would have called it the same this time. The posterior fossa is not enlarged. It's not irregular. Some of these kids, we have stopped the pregnancies and we have not really seen that. Then that's another problem. The pathology does not correlate with the prenatal diagnosis, and it doesn't really help us become smarter, because some of these cysts then deflate and the appearance of the vermis is almost normal. So we're very confused, and I will just end this lecture, even though I know that we have a couple of things with a later case, and this is actually one of the cases, earlier cases, that we thought was a vermial hypoplasia. We looked at the 26 weeks of age. These are, again, old films. At 32 weeks of gestation, I thought it was almost normal. And I was wrong. I was very wrong. When you look at the ultrasound, now look carefully on the ultrasound images, then you can see the superior aspect of the peduncle and the squaring of the fourth ventricle. This was the Joubert case. And even postnatally, when you look at the postnatal that was done a few weeks after age, and this is part of the problems that we have on fetal MRI, if you don't do very thin sections, you're going to get the vermis and part of the cerebellum, and these are 3 millimeter sections. So you may not make the diagnosis, and actually in this case, the diagnosis was not made. Took some time, even on the MRI. You can see other things such as the thinning of the midbrain and the angle, and I'm not showing you the nice axial images of the classical molar tooth anomalies and the elongation of the superior cerebellar peduncles. Rhomboencephalosynapses. I think I'm going to stop right here because this is really getting into and give the okay. Thank you. I'm happy I confused you even more.